Marianne Opilla is a nurse who had her training in Virginia at the Commonwealth University. She's a certified nutrition support clinician and a member of the clinical team of NutriShare. Her topic today is central venous catheter life in very long-term home parenteral nutrition patients. So Marianne, my clock's starting.
You won't have to worry about me with that. And I guess Lori stepped out, but her talk was a perfect segue to this abstract. Myself and Rodney Okamoto from NutriShare in Elk Grove, California, worked on this project. And it was presented originally at Clinical Nutrition Week earlier this year in February in Austin, Texas. And intestinal failure patients often require long-term parenteral nutrition, which transitions from hospital into the home setting. And home parenteral nutrition is infused through a central venous catheter, but that catheter, most importantly, becomes a lifeline and needs to remain in as long as possible. Several complications, though, are associated with CVC removal. Central venous bloodstream infection, site infection and failure, thrombosis that's very extensive and often the catheter has to be removed, occlusion that cannot be resolved through use of alteplase or good flushing, and just generalized malfunction. Sometimes tips come out, sometimes repairs need to be done, holes, tears, that kind of thing, result in catheter removal. And repeated removal and replacement of the central venous catheter over time results in loss of venous access sites. So maintaining that trouble-free central venous catheter is definitely a goal and a priority for anyone that's on home parenteral nutrition. So the aim of this study was to examine a group of very long-term home parenteral nutrition patients and report their longest catheter history. This was a retrospective chart review from one home infusion pharmacy. We studied the charts and we looked for CVC history, and we used all adults and pediatric patients from that home infusion pharmacy were included. We also collected data on age, gender, diagnosis, years on home parenteral nutrition, and the CVC type. We recorded the longest number of days that one individual CVC remained in place. So if a patient had 5 catheters, we only looked at that one that was in for the longest period of time. And the inclusion criteria were that the patients had to be on home parenteral nutrition for at least 3 years, and that they had a CVC in place for at least 2 years. So for demographics, we had 103 total patients included. That was 91 adults and 12 pediatric patients defined as less than 18 years of age. 60% were female. The average age was 49 with a range of 9 years to 90 years. 70% had short bowel syndrome of all causes. 27% intestinal pseudoobstruction, all causes, and 3% radiation enteritis. There were 1,995 total HPN years included for all these 103 patients. The average patient was 19 years, so these were very long-term folks with a range of 4 years to 39 years. For all patients totaled, the catheter days were 291,744 days, and what that means is about an average of 7.7 years. Again, long-term catheters. The adults had a range of approximately 8 years, and the pediatrics had an average of approximately 4.88 years with their groups. There were 81 tunneled catheters for a total of 251,115 CVC days. 67 were single lumen open-ended silicone catheters. And what that means in terms of what kind of catheter is that? That's the catheter we've been using since TPN began. Okay, Dr. Hickman, Dr. Broviac invented these catheters, and there are some different manufacturers that have taken that same technology and created catheters, but it's really the same one we've been using since home parenteral nutrition started. 4 of the catheters were single lumen valved silicone catheters, 6 were double lumen open-ended silicone catheters, 3 were single lumen polyurethane, and 1 was a triple lumen polyurethane. There were 16 implanted infusion ports for 31,236 CVC days and 6 peripherally inserted central catheters, or PICCs, for 9,393 days. So we had some pretty old ports and PICCs also. So we decided to divide it into, we'll really get some detail with some of the years. So catheters that were in place for 15 or more years, there were 12 tunneled, no PICCs and no ports. Catheters that remained in place for 10 to 15 years, there were 13 tunneled CVCs, 1 implanted port, and no PICCs. And then 5 to 10 year range, there were 27 tunneled CVCs, 6 implanted ports, and 1 PICC. So I think the port data was the most interesting to me, that some ports were in for 5 to 10 years. We usually don't see them last that long. And of the 25 tunneled CVCs lasting 10 years or greater, those catheters were exclusively single lumen, open-ended, silicone-style devices. So in conclusion, various CVCs can be safely maintained for many years without serious complications requiring removal. Tunneled CVCs, especially single lumen, open-ended, silicone style, last significantly longer than PICCs or ports for long-term parenteral nutrition. And the pediatric CVCs in this group actually experience less complications resulting in removal than is generally reported in the literature. So it's a really strong pediatric group, and we have to thank the caregivers and the parents along with the pediatric patients for that. Thank you, that's it.
I think Marianne was really worried about this floor opening up. You did it.
How many minutes? Probably 8 minutes or so.
It was almost 10, but not quite. So, question over here. No, wait. Yeah. Don't forget to leave my
So regarding the CVCs, I wanted to ask about location sites for Broviacs and Hickmans. We've seen different locations for peds, and just interested in knowing location for these long term.
I didn't collect data on that, but I can tell you that they were primarily chest placement, upper vessel placement.
Just to follow on, our daughter has had four Broviacs, 1 port, 5 PICCs, and dozens of IVs. She's on her 5th PICC right now on her arm, and we're facing the decision: do we pull it to put in a new Broviac, or do we leave it in longer than the normal 2 to 3 months? Does any of this data give insight? I mean, should you remove a non-tunneled line to put in a tunneled line, or just leave it until you don't need it anymore, until it malfunctions?
I have collected data on PICCs. I did an abstract on PICCs alone, and they can stay in for years. If it isn't broke, sometimes you don't want to fix it. It depends on, though, what else is going on with your daughter: infections, thrombosis, what the bigger picture is, because we always have to look at that. But PICCs can stay in for a very long time if they're functioning and not infected. So.
Just out of curiosity, on your PICC analysis, did you look at the incidence of thrombus in those PICCs?
I did, and there in the PICCs that there were no PICCs removed because of that. And I also went back and looked at tip placement on the ones I had documentation for, and tip placement is very important with thrombosis, development of thrombosis. You want the tip at the junction of the superior vena cava and the right atrium. Anything proximal or higher up in towards the shoulder, you are much higher risk for thrombosis. So I did look at that data, and none of the PICs that I looked at that were over a 5-year period were removed because of thrombosis. Most of them were removed because of infection.
Other questions? Yes, over here.
Did you find reason why the silicone lines lasted longer than the polyurethane, or were there other factors involved, such as a single lumen versus double lumen? And what do you recommend for a Hickman placement, a silicone versus a polyurethane?
Well, I absolutely recommend silicone. And I think this data today shows that. Those are the ones that stayed in the longest. Silicone is a material that's very easily accepted by the human body. It adapts. It's in there. There's no allergic reaction to it, and it's a very comfortable line. It can be repaired if it gets a hole in it, whereas polyurethane cannot be repaired. That's a very tough material, but it does crack. It does get holes in it. The lumens crack. So we don't see the comfort with the polyurethane that we see with the silicone catheters. And this is just reported anecdotally by patients, but the silicone is much more comfortable. I think it's the oldest one. It's the longest one we've used, but it seems to be the best. I like a single lumen because more lumens, you have more potential for infection because you're accessing 2 lumens. You have to flush 2 lumens. There's also a lot of bulk underneath the clothing, which people, you don't want anything extra there. It's just something else you have to cover up or tuck in or whatever. So I stand tried and true. Single lumen, and you may have to be your own advocate when you're in that radiology department and you're planning a Hickman. You need to ask them to get that off the shelf. Get the single lumen silicone open-ended catheter off the shelf. Don't pull the polyurethane, purple, whatever. You have to, again, step up and be your own advocate.
Hi, I have a question about the life of a port looks like they don't obviously last as long. When it comes to being the end of using that port, if you're not prone to getting infections, I've had mine about a year, but if I keep it for 5 years, do you at some point say, okay, it needs to be replaced, or you just kind of wait until something goes wrong? I mean, as far as having it removed or getting a new one placed.
The ports advertise about 5,000 sticks, so you can do that math. What I find with a port is site failure. The skin becomes thin because you have accessed it quite a bit and there's some scar tissue. So the skin either thins out across it and you can actually see the port under there, and that's an indication to remove it. Secondly, you may have some leakage at the site where the septum has just been stuck so many times in the same place that it's leaking. And that's the primary reason the older ports are removed, in my experience.
Just a comment about, I'm on a PIC. First of all, do you recommend a double lumen? I have a double lumen, and just because of blood draws, but is a PIC different on the recommendation? Do you recommend single lumen?
I always go with a single lumen
Okay.
unless you have other medications or other infusions.
Next thing is, I understood from ethanol studies that the ethanol works better if you use the ethanol rather than heparin that it works better with the polyurethane as opposed to the PIC.
No, ethanol lock is contraindicated in polyurethane. You only want to put it in a silicone catheter.
Okay.
It will crack the polyurethane tubing. So,
Okay,
yeah.
fine. And then the last one was just quickly on your you did from what, 2 years and beyond for this study? People had to have had these for
At least 2-year
So
catheter.
did anybody look early? Is there any difference, do you think, in those for the first 2 years that would make any difference in the results?
That has been published. There's a learning curve. And I wanted to just kind of avoid the learning curve where people do get infected because their technique's not as refined. And so that's why I wanted to just start out with an older catheter and someone who had been on TPN for longer.
Thank you very much, Marianne.